But thanks again, Robbie, for inviting me back to do these webinars. I think they're really useful, and I'm really excited to talk to you all today about our work in gambling and impulsivity. And my background is as both a clinical psychologist and as a clinical researcher, working in the area of addictions for the last 20 years or so. About half of the work that I do is in gambling disorder research. And one of the things that I've found over those years is that impulsivity, as far as personality traits, is one of the most important things that we can focus on with people who have gambling problems. So what I want to do today, if I can make my slides go, is just sort of jump right into that and talk about how assessing and treating impulsivity can really help you treat your problem gamblers. I'm coming to you from Windsor, Ontario, and Detroit, Michigan, and this is what my home looks like. I actually live over in Canada, so what it looks like during the summertime. There's a lot of fun things to do, including the bottom left of this slide is the gigantic Caesars Windsor Casino, which is right across the river from Detroit. And I have the distinction of passing by 4 huge casinos on my way to work every day, because I do the hop across the border. Unfortunately, this is summer, and this is this is what it looks like right now. The Detroit River is pretty much iced over, and there are these small sort of icebergs that are just floating down the river. It used to be the case that people could drive across the river, and during the 1920s, the bootleggers would actually put all their crates of whiskey in the back of their cars in Windsor and drive them across to Detroit. I'm not going to be doing that today. We now have a bridge and a tunnel, so I'll just use those. But what I want to talk about is sort of related to this idea that gambling disorder has been categorized a lot of different ways over the years. It's been categorized as a mental health problem. It's being categorized as an impulse control issue. And in fact, up until until the introduction in DSM-5, gambling disorder was actually considered an impulse control disorder, not otherwise specified. But as of the DSM-5, we now consider it alongside the addictions, alcohol use disorder and substance use disorder, as an addictive disorder. And I usually introduce this as a discussion question. I think what I'll do is just have you all sort of think to yourselves, what do you consider gambling disorder to be? Do you consider it to be an addiction, a mental health problem, an impulse control issue, something else, a combination of these things? And what are the things that make you believe that it fits into those categories? And I say that because, in part, I assume that all of you are problem gambling clinicians who have done quite a bit of work with people with gambling disorder, and you've seen how gambling disorder manifests across a lot of different people. And you know that not all problem gamblers are the same, but there are some traits that are similar across many people with gambling problems. Also, as I go through my talk today, I want you to consider the case of Dolores. And Dolores is not this woman's real name. This is someone who I saw a few years ago. At the time that I saw her, she was a 50-year-old single African-American businesswoman in the Detroit area. She was gambling out of control. She was actually the head of a small business, and what she would sometimes do was go to the casino and spend her personal finances into the red. Basically, her bank would allow her to take out more money from her bank account than she had in there, and then she would switch to the payroll for her company and start spending that money. So she would get in a lot of trouble spending payroll that was meant for her employees, and also spending her own money, and it ended up resulting in her having some major problems with the IRS and so forth. But she also had a history of childhood sexual abuse that resulted in longstanding depression. She had past dependence on opioids and cocaine and alcohol. But at the time that I saw her, she had been in recovery from substance use disorder for about 20 years. And her gambling disorder had been off and on for over several years, but over the past 5 years before she came into treatment, it was essentially at its worst. So this is somebody who was otherwise successful. She had actually come through a long history of substance use disorder, went into long-term recovery. She was a really smart person. She was sort of an entrepreneurial business person who actually created a very successful business. So she was not dumb. She was not she was actually quite successful and intelligent person, and yet she would engage in this out of control gambling to the point that she would actually spend not only more money than she had in the bank, but also the money that was required for her business. When we think about that kind of behavior, it doesn't make a lot of sense to many of us, and we start thinking about impulsivity. How impulsive is this person that she would blow through that much money without thinking this is a bad idea? Uh, Now, of course, as I just mentioned, we've seen a major change in gambling disorder in the last few years. So it's no longer an impulse control disorder. We've changed the name to gambling disorder from pathological gambling. We've dropped the illegal behavior symptom. So it was a symptom that basically stated people gamble as a way to gamble uh, as a support their gambling through illegal behaviors, either to steal money to gamble with or to steal money to bail themselves out of a financial situation. And now instead of 5 out of 10 symptoms on the DSM, we need 4 out of 9 symptoms to have a diagnosis of gambling disorder. And this was done in part to make gambling disorder a little bit more consistent with the diagnosis of substance use disorders, which requires fewer symptoms. And now, for the first time, gambling disorder is considered an addiction, and it's considered alongside the alcohol use disorders, tobacco use disorders, and substance use disorders. It is the only behavioral addiction that's actually included as such in the DSM-5. There's one other potential disorder, internet gaming disorder, which is actually included in the DSM-5 as a disorder for future study, but it hasn't been sort of designated as a disorder, an addictive disorder alongside gambling disorder and the substance use disorders. So when we think about gambling disorder, and I didn't put all of the symptoms of gambling disorder up there, as I stated, it's moved from this category of impulse control disorders not otherwise specified into the substance use category. And one thing that gambling disorder has in common with the substance use disorders is a high level of impulsivity. And impulsivity becomes a very important construct, as does another concept called executive function. And most of my talk today is going to be about these two things and sort of how this influences gambling disorder development and also treatment, how we can address it. So this sign says, "Be careful, crocodiles in their natural environment." And as you see at the top, it says, "Gambling involves placing something at risk in order to obtain something of greater value." And I took this picture when I was in Mexico, and it looks like maybe I was engaging in some risky behavior, got down on the ground and tried to take a snout-to-snout picture of a large crocodile. However, I was actually standing on a wooden platform, perfectly safe from the crocodile. So we generally take calculated risks where the potential payoff is consistent with the reward. So a great picture of a crocodile is probably not worth my life. I just need a camera with a better zoom lens so I could take a picture from a little bit higher up. That's one way of looking at impulsivity. So this idea of taking risks that are probably not advised. Another way of looking at impulsivity is sort of characterized by this sign. So you'll see the sign says basically caution. This sign has sharp edges. And then the letters get a little bit smaller. It says do not touch the edges of the sign. And then you'll see at the very, very bottom of the sign in very small letters, it also says also the bridge is out ahead. Now, if you're looking at the sign, it's kind of funny because it seems to me that the most important information if you're driving along is that the bridge is out ahead, and yet this big caution sign is telling you that not to touch the sign because it has sharp edges. Well, this sort of indicates another type of impulsivity, the degree to which we can pay attention to the right things, right? So the most important information here being that the bridge is out ahead is probably lost in this bigger message of caution. The sign has sharp edges and blah blah blah, and if you touch it, you're going to cut your hand. Well, that's probably somewhat irrelevant because who's going to go up and touch the side of that sign? But when we think about impulsivity along with risk taking, we can also think about people who get distracted by details that are really not relevant to the situation that they're in. And then there's this version of impulsivity. This is probably the one that most of us think about when we think about impulsivity, and I call it the Dennis the Menace definition. By the time I think about what I'm going to do, I already did it. So it's basically engaging in behaviors without thinking them through before engaging in them. And oftentimes when you do that, bad things happen. You make mistakes, you get into trouble, and so forth. So there's a lot of different ways of measuring impulsivity out there, and many of them are actually available online in the public domain. There's a number of measures that are sort of paper and pencil measures, like the Barrett Impulsiveness Scale, Isaac's Impulsiveness Scale, and the UPPS, two of which I'm going to talk about in a minute. I'm going to talk about the Barrett and the UPPS because I think that they're both very useful measures of impulsivity. They're both available online for free. So as a clinician, we like to be able to get assessment tools that are both valid and available for free. And they're also fairly easy to interpret. And I think they're a good thing to add to somebody's initial intake packet to see exactly how impulsive they are and in what ways are they impulsive. But there's also a lot of other sort of computer tasks that we do in research projects. For example, there are attention and memory types of tasks. There are risk-taking tasks. There's one called the balloon analog risk task, where people will blow up a balloon on a screen. And the idea is to stop blowing up the balloon and take the money you've accumulated with each push of the mouse before the balloon actually blows up rather. There's go, no-go tasks, which are what we call response inhibition tasks. And this is an important sort of construct in impulsivity. It's the idea that oftentimes when we're given a go signal to go and engage in a particular behavior, we might start to engage in that behavior, and then all of a sudden we're given a sudden stop signal. And that stop signal, how we respond to that stop signal is an indication of how impulsive we might be. So a good example of that is if those of you who came into work today were driving down a very familiar, fairly busy road that has a lot of traffic signals on it, and you are coming up to a familiar intersection, you can imagine that if the light is green, there's probably a point at which there's this point of no return, where if the light turns yellow, before you get to that point, you're likely going to stop at the light. But if the light turns yellow after you get to that point, you're probably going to go through the yellow light. Well, let's say you're driving down that road, and instead of turning from green to yellow to red, the light instantly turns from green to red. All of a sudden, you're given a very different type of stop signal. So how good are you at reading that stop signal and making an appropriate stop without sort of just barreling through? So that's another type of impulsivity. And the third, or the last type, is something called discounting delayed rewards. And I'm going to talk to you about that one in a few minutes, because that's sort of a special case, and it's something that we've done some research on, and I'd like to show you some of our results there. So the first measure that I want to talk about is Barrett's Impulsiveness Scale. It was created by a guy named Patton and a guy named Barrett, and in 1995 they developed the most recent version of the scale, version 11. This is a paper and pencil measure that basically gets at a number of first order and second order sort of factors related to impulsivity. And in my experience, the most useful and interesting are the 3 second order factors. So there's a measure of attention impulsivity. So the ability to pay attention to things, to have sustained attention in situations that require sustained attention. There's motor impulsivity, so the degree to which you don't get, or you get fidgety or restless in situations where you have to wait. And there's non-planning impulsivity, or the extent to which you're able to or not able to plan out activities that require a lot of steps. And here in this slide, I basically did a screenshot of this measure to show you some of the questions that they ask on this particular measure. So for example, the first question is, I plan tasks carefully. And the response options are never or rarely, occasionally, often, or almost always, or always. So somebody who is less impulsive would probably give that a score of 3 or 4 because they feel like they plan tasks fairly carefully. I do things without thinking. So you'll see this is sort of a reverse scored item. And sometimes questionnaires have reverse scored items. So it's important to pay attention to the scoring keys of these particular measures if you use them clinically. So I do things without thinking. Someone who's more impulsive would give that a 3 or 4. Someone who's less impulsive might give it a 1 or a 2. I make up my mind quickly. I'm happy-go-lucky. I don't pay attention. I have racing thoughts and so forth. So you see by the items, they get at impulsivity, but they also get at different sort of aspects of impulsivity. This measure I found is particularly useful for even giving feedback to clients. Once you give them this measure and then you score it up and look at their scores in various sort of scales, subscales on this measure, you can say, so it looks like you have some difficulties relative to other people with planning, for example. So this is one that I would recommend. Another questionnaire that I would recommend clinically is called the UPPS, and it was developed by Whiteside and Lyman in 2001. And initially it had 4 main scales, which was basically made up the acronym name UPPS. So the first scale is negative urgency, where a person will act rashly or impulsively when they're experiencing negative emotional states. So you could think of this in terms of disinhibition when someone is upset or depressed or angry or other things, or even excited. The second is lack of premeditation, or again, the Dennis the Menace definition of acting without thinking. Then there's lack of perseverance or inability to remain focused. So this is a little bit like the attention impulsivity on the Barrett impulsiveness scale. And then there's sensation seeking, or seeking out novel and thrilling experiences. So we all know people who like to skydive, or like to do things that are risky and thrilling and novel, and they would score high on the sensation seeking scale. So there are short and long forms available of this measure, and some of these measures, including the Barrett measure, actually available on this website, www.impulsivity.org. And this is a research organization I believe in Europe, it was set in Europe, that is an organization of scientists who do impulsivity work. And a lot of them have actually posted their research and also posted their questionnaires and measures on that website free for download. So I would definitely recommend going to that site. There are a number of different sort of things that you can sort of try out there. But here's the short version of the UPPS. I added this so that you can get, again, in comparison to the Barrett, you get some context as to how they ask these questions and what kind of questions they ask. So I generally like to see things through to the end. So that would be somebody where if you strongly agreed to that statement, you'd probably be less impulsive. You're more likely to persevere, you have higher perseverance there. If you were more impulsive, you might disagree with that statement. My thinking is usually careful and purposeful. Obviously, again, loaded for lower impulsivity. So you'd strongly agree if you were less impulsive. When I'm in a great mood, I tend to get into situations that could cause me problems. So this is a little bit more on the other side. So loaded towards more impulsivity, including the negative urgency aspect. Unfinished tasks really bother me. So again, This is loaded towards being lower impulsiveness. So if someone who likes to persevere and actually finish things and so forth. I like to stop thinking things over before I do them. When I feel bad, I often do things I later regret. Once I get going, I sometimes hate to stop and so forth. So again, just like the Barrett impulsiveness scale, this measure gets at various aspects of impulsivity, and it's quite useful from both understanding your client and also even helping the client understand him or herself and the traits that he or she sort of experiences that might be related to their gambling. Now, the last type of impulsivity I wanted to review with you is, again, this discounting of delayed rewards, or sometimes we call it delayed discounting. And as we go through this, for those of you who've never heard of this before, there's a couple of things I would sort of mention. One is that this is a concept that's a little bit like delay of gratification. So the ability to put off for the future something positive instead of having it right now. Those of you who know the psychological research literature might have heard of the marshmallow experiment. So in the marshmallow experiment, which was done in the 1970s, was a measure, there was a test of childhood impulsivity. And what the researchers did was they would bring a young child into a room with a research assistant and sit down, and a video camera, and sit down with the child and put a marshmallow in front of the child, or some other type of candy or other treat in front of the child. And the researcher would basically say, here's a marshmallow. If you can sit through the next 5 minutes until I come back, you'll get a second marshmallow. So most children really couldn't sit through that, but there was also a video camera in the room. And so they basically videotaped the child, and they timed the amount of time it took from the time that the researcher left the room to the time that the child ate the marshmallow or the candy. And that turned out to be a really interesting measure of sort of delayed gratification or impulsivity as we're assessing it now. And what they found was that kids who are more impulsive tended to have more trouble later on, trouble in achievement, school achievement, other types of areas. They also found that younger kids tended to have poor impulsivity or impulse control compared to older kids, which totally makes sense. Well, there's an adult version of that task too, and the adult version is called the discounting delayed rewards task, and it's usually a monetary task. So it's about hypothetical money rewards, and we ask people to sort of make selections based on their own experience. And so we're not going to have a discussion here because it's kind of difficult in this setting with 50 plus people on the line. But what I want you all to do is just imagine what your response would be to each of these items, or you can even write it down if you have a pad of paper with you. So the first question is, if I offered you $1,000 now versus $1,000 in 1 month, how many of you would take the $1,000 now? So think about that, write it down if you want to. But I would imagine that the vast majority of people on the line would take the $1,000 right now compared to the $1,000 in 1 month. Now, what if instead of offering you $1,000 right now, I offered you $900 right now versus $1,000 in 1 month? Think about whether you would take the $900, you would consider taking $900 instead of waiting a month for the extra $100 you would get if you took the $1,000 in a month. Now, what about this? What if the amount was $500 now? So $500 now or $1,000 in one month. In my experience in doing this in a room full of people, there are always a few people who would take the $500 now. Most people would probably wait the month for the $1,000. Then if we go down to $200 now versus $1,000 a month, if there anybody out there who would take the $200 now, think about that. My experience, most people would wait 1 month for $1,000. Now that just shows the first part of this particular task, which is the amount of money you might take now versus the amount of money you might take in a month. But what if we changed the delay period? So instead of a month, we said it was a year. So now if I asked, would you take $900 now or $1,000 in 1 month? Some of you who before said you would wait a month or wait a month to wait for the extra $100 might now say, I'm not waiting a whole year for the extra $100. I'll take the $900 now. Similarly with the $500, some of you who said, I will wait the delay period to get the extra $500 might now say, well, if the delay is a year instead of a month, I'll take the $500 now. And a few of you may also decide to take just the $200 now, instead of waiting a whole year for the extra $800 you get if you selected the $1,000 in a year. So you could see how the choice that you make is not just dependent on how much money I'm going to give you, but it's also dependent on how long you have to wait for the larger amount. Now, this is sort of brought home even more if I said the delay period instead of 1 year or 1 month is now 10 years. When I've done this in rooms with people and have them put their hands up, if I ask them not if they want $900 now or $1,000 in 10 years, most people would actually say, I'll take the $900 now. A lot of people say they'd take the $500 now, and quite a few people even say they would take the $200 now. So again, this shows that idea of like our decisions about rewards and accepting rewards is based not just on how much we're offered, but also the extent to which we have to wait for it. So we discount delayed rewards. We have a tendency to accept a smaller, more immediate reward over a larger delayed reward. And that's a function of both the how much you're going to get now, how much you're going to get later, and how long the delay is. So that is something that all people do, all humans do this, they discount delayed rewards. And it's also true that people who are more impulsive are more likely to discount delayed rewards than are people who are less impulsive. And we did a study about this a few years ago. We published in the journal Drug and Alcohol Dependence, where we looked at people who had gambling problems and people who didn't have gambling problems. So people who were what we call otherwise healthy controls. And we took the people with the gambling problems and we divided them up into two groups. There were people with gambling problems who did have a history of substance use problems, and problem gamblers without a history of substance use problems. So in this study, we had three groups we were comparing. And this is basically what we found. This graph, which takes a little bit of getting oriented to, basically has three slopes on it. And you'll see that there are two slopes that are towards the bottom of the graph that are almost right on top of each other. And then there's the solid slope at closer to the top of the graph that's quite a bit higher than the other two. And what this basically shows is that in the top slope here, people who had no history of addiction, whether it was gambling disorder alone or gambling disorder plus substance use problem, if they didn't have any of those things, they tended to discount delayed rewards at a rate that wasn't very steep, right? So that you see that this line is not very steep. It sort of gradually goes down, and especially in comparison to these two lines. So these two lines, including the dotted line, was problem gamblers with a history of substance use disorder, and the dashed line with the open squares was problem gamblers without a history of substance use disorder. And you see that these two lines are almost identical. And you also see that there's a much steeper drop-off in this line over time. So there's a delay in weeks at the bottom, and on the left-hand side is the amount of money. And this is the point at which they would switch from accepting the money right now or later, essentially. And so what these data show is that people who have gambling problems, regardless of whether or not they have a substance use history, are significantly more impulsive when they do a delayed discounting task. They're much more likely to discount future rewards in favor of smaller, more immediate rewards. And that is important because how we process rewards has a lot to do with how we benefit from our learning experiences. So you can imagine somebody who has a gambling problem coming into treatment, and you sit them down and you say, what are your goals for the next 5 years? Most people with a gambling problem who come into treatment with you and hear that question would say, I have no idea. I don't know what I'm going to be doing tomorrow. So it's something to consider when we're treating people with gambling problems. And it has to do with how we process rewards. And so what we do know is that broadly across nearly all measures of impulsivity, problem gamblers tend to score higher on measures of impulsivity than those without any gambling problems. Gamblers generally tend to score similarly to those with substance use disorders, but it's not always the case. And also, higher impulsivity among problem gamblers is associated with poorer treatment outcomes and higher treatment dropout rates. So we know that from a relatively small number of studies that have been done so far, impulsivity is associated with poorer treatment outcomes among both people with substance use problems and also people with gambling problems. Another concept that's actually quite important here is something called executive function. And executive function involves like higher level cognitive brain processes that are implicated in the formation of successful goal-directed behavior, including planning and initiating behaviors, anticipating positive and negative consequences of actions, and the ability to adjust behaviors based on environmental feedback. So this is a long-winded way to say basically executive functions are those are those cognitive functions we use to learn from our environment, to maximize our rewards and minimize our punishments, essentially. And it's made up of a lot of different sort of constructs. So when we're thinking of executive function, when we're studying it, we're really using sort of the first line here is executive cognitive function. So planning, monitoring, activating, switching, inhibiting of lower level functions. But it can also involve sort of emotion and reward processing, behavioral self-regulation, initiation, and energizing of behaviors or motivation to engage in activities, and also the sort of metacognitive processes like our personality and our social cognition, our ability to think about relationships, our self-awareness, and so forth. All of these things factor into our executive function. In this particular talk, I'm going to talk mostly about these four constructs of executive function. One is response inhibition, and that's that go-stop type of construct that I already talked about when I talked about driving down the road and you see a green light and all of a sudden you get a red light. So we call that response inhibition. Another aspect of this is what we call working memory. It's the ability to maintain attention to details that are essential in planning things out. So if you think about all the things you have to do in a task while you're planning something at work, you probably have to remember a whole bunch of steps, right? There are things you have to keep in your short working term memory, and you can forget about them once you've done them, but you have to be able to have some capacity there to remember all the things that you need to do. Then there's something called cognitive flexibility, and the flip side of that is perseveration. Cognitive flexibility is sort of the idea that if we're in the middle of a task and then all of a sudden the rules change around that task, we can flex with that, right? We can realize and understand that something has changed, we change both our thinking and our behavior to sort of pivot with whatever we have to do at that point. Someone who's perseverative has a lot of difficulty with that. You can imagine if you're playing like a computer game and you get to know the rules of the game, you get to be pretty good at playing it, but then all of a sudden there's some programming in that computer game that changes the rules of the game midstream. So now all of a sudden you're playing terribly because you're making mistakes and you don't understand why you're making those mistakes. Well, cognitive flexibility, if you're high in cognitive flexibility, you would have an ability to sort of recognize that, realize there's new rules. I have to figure out the new rules. You would learn the new rules fairly quickly and move on and improve your game. Someone who is perseverative will have much more difficulty with that. And so there's some evidence that people with substance use problems are more perseverative. We also know that people are older. As you get older, you become more perseverative and have less cognitive flexibility as well. And then these all come together. I think the culmination of all of these executive functions is planning, or the ability to identify and organize elements needed to carry out a planned act or achieve a goal. So if you could imagine spring break is coming up, and you want to take your family on vacation to Mexico or some other country, there are a lot of things you would have to do to plan for that. You would have to book a hotel well in advance, book flights, make sure the kids have had their vaccinations, make sure you have your passports up to date, make sure you know the dates of the trip, make sure you haven't double booked any work meetings during that time, and so forth. Most of us do a lot of planning in our day-to-day lives. We often have complex lives and complex things we have to figure out, but people are sort of differ in the extent to which they're good at that. Some people are really good at planning. Some people have a lot more difficulty at planning, and part of that is because of these other executive functions that we're also talking about. So impulsivity and executive function deficits impair a person's ability to learn from their experience, to make plans based on their long-term consequences of their behaviors. We know that treatment is geared towards long-term consequences. As I mentioned to you, if you asked somebody with a gambling problem what their 5-year goal is, they would probably not, they'd probably look at you blankly and say, I have no idea. So people with gambling problems can sometimes also have a greater difficulty benefiting from treatment because of these difficulties. And so oftentimes we have to think about treatment as, how do we sort of initiate treatment in such a way where people can engage in short-term goals that result in shorter-term benefits, at least initially, and help them to string together sort of longer-term goals as treatment continues. So just very quickly, I wanted to talk about this one study by Gudrian and colleagues, where she actually recruited 49 people with gambling problems, 48 people with alcohol use disorder, 46 people with Tourette syndrome, and 49 participants who are healthy control participants. And she looked at several measures of response inhibition. If you look at this graph, you'll see this blue line. These are the people with gambling problems. And at the bottom, you'll see a number of different types of executive functions that we've already talked about. If you imagine that the zero line, the straight line that's at the zero mark across the screen, are people who are in the healthy control condition, this blue line is the problem gambler score relative to people who are in the healthy control condition. So as you see, problem gamblers relative to controls did pretty poorly in their response inhibition tasks, in their cognitive flexibility tasks, so they tended to be more perseverative, and also in their planning tasks, so the one on the very far right of the graph. When we actually add one more line, this red line is people who have alcohol use disorder. We see that these lines actually line up somewhat to a certain extent. We see that problem gamblers and people with alcohol use disorders actually have similar deficits in response inhibition, in cognitive flexibility, and in planning. So what we're seeing here is essentially that these two addictive disorders have a very similar pattern of executive function deficits, despite the fact that one of them, the alcohol use disorder, involves ingesting a toxic substance, alcohol, whereas the problem gambling disorder does not. So we can't say it's just due to toxic substances introduced to the brain over many years, and see that there's something about gambling disorder that where people with gambling disorder have some major deficits in both impulsivity and executive function. So early studies suggest that people with gambling disorder exhibit executive function deficits. When we look at brain function, it gets to be a little bit more complex. And there's a couple of articles that I mentioned here, one by George Koob, who is actually the head of the National Institute on Alcoholism and Alcohol Abuse, one by Nora Volkow, who's actually the chair of the National Institute on Drug Abuse. And these two quotes basically both reflect the idea that people with addictions have basically a reward circuitry in the brain that's been hijacked essentially by their addictive processes. And I'm not going to get into the brain too much. There's a lot here, so that's probably something for a future talk. But if you look at this picture of the brain, you see those main areas that are actually associated with reward processing in the brain, including the striatal area of the brain, which is all those parts of the brain that are involved in dopamine production and reward, and sort of the reward center of the brain. The frontal areas of the brain, including the dorsolateral and ventral medial prefrontal cortices, are involved in executive function or learning. And then you have other areas, the amygdala, which is important for both formation of emotion-based memories and also for emotion processing, and the hippocampus, which is important for learning and memory. So these are areas of the brain that are really sort of interest when we look at people with addictions, including gambling disorder, to see if their brains differ from people who don't have addictions. And here's just a list of the areas that are important. The striatum is the sort of reward center of the brain. The nucleus accumbens is in that part of the brain and is our pleasure center. Dopamine levels are higher when drugs or gambling are on board. Even cues that remind one of gambling or drugs can increase dopamine release in the nucleus accumbens. The prefrontal cortex is that part of the brain where we're really using our sort of thinking, we're learning from our experiences, and we're engaging in more behaviors that increase benefits, maximize and minimize risks. Hippocampus, formation of novel memories, amygdala, memories about emotional reactions, and then the insula is a very important part of the brain that is involved in self-awareness and self-consciousness, and also drug craving and gambling craving. If we didn't have an insular cortex, we wouldn't be aware of when we're craving gambling or craving drug use. There's been quite a bit of research out there in the substance abuse world about dopamine and how dopamine is sort of related to addiction. And across numerous dozens of studies, substance use studies have shown that reductions in dopamine D2 and D3 receptor availability in the brain has been associated with nicotine, alcohol, cocaine, methamphetamine, and other drugs of abuse. So you see this slide, classic slide on the left-hand side, was studied by Nora Volkow, which shows a PET image of a comparison healthy control subject, and at the bottom, someone who is dependent on methamphetamine, and you can see the striatal areas of the brain. There's much more availability of dopamine receptors in the person who is a healthy control than the person who has a methamphetamine use problem. When they've looked at gambling disorder, we've seen, I'm just going to skip through a couple things here, go back. When we've looked at gambling disorder, we've basically found mixed results with regard to dopamine receptor availability. There have been one or two studies that show some evidence that D2 and D3 receptor availability is less for people with gambling problems than people who don't have gambling problems. And why this is important is a couple of things. For one, if you don't have dopamine receptor availability, then your sort of reward center is a little bit messed up. You can't get rewards from the things that normally sort of are rewarding, like our relationships, like having a good job, like all of these things we usually take for granted if we don't have an addiction. The other thing is there's only mixed evidence to suggest that problem gamblers' brains are the same as people with substance use problems in this respect, in terms of dopamine receptor availability. So there'll just be more research on that to get a better understanding of this. So again, back to this idea of risk and reward. Gambling involves placing something at risk in order to obtain something of greater value. And we generally take calculated risks where the potential reward is consistent with the payoff. So what does all of this mean for the treatment of people with gambling problems? Some problem gamblers seek treatment, will have trouble working towards long-term goals. They may perseverate, they may have difficulty changing behavioral skills without help. Because of their increased impulsivity and possible executive function problems, they will have trouble sort of benefiting from long-term goals right away, and you may need to develop strategies that will help clients to direct their own behavior, to keep long-term consequences in the forefront of their thinking. So getting people to think initially short-term with the idea of lengthening the term that they can tolerate in terms of understanding what their long-term consequences of their gambling will be, and what the long-term benefits of stopping gambling might be. Now, this might all sort of sound like sort of pessimistic. Our problem gamblers that we're treating may have a really difficult time getting better because of this level of impulsivity. But it's also, and I'm going to end with this, important to understand that not all problem gamblers are actually the same. We did several studies. This is one of them where we were actually looking at different subtypes of problem gamblers, and we developed along with a way of actually dividing problem gamblers into different subtypes based on Alex Blazinski and Leah Nauer's pathways model, which some of you may have heard of before. If not, that might be a topic for a future talk. But we've identified that there are different types of problem gamblers. There are some problem gamblers who gamble with that level of impulsivity, that high impulsivity that gets them into trouble, but not all gamblers are that impulsive. There are also some gamblers that tend to gamble because of depression or anxiety, and this is a way for them to zone out. And some of them are not impulsive at all. And then there are some problem gamblers who just gamble because they have gotten sort of sucked up into the contingencies of the gambling games themselves. Maybe they had a big win earlier in their gambling career, and they started to realize that they can make money gambling until all of a sudden the bottom falls out and they're chasing their losses. Well, these three different types of gamblers are behaviorally conditioned gamblers. Those are the ones that I just mentioned who are not very impulsive and maybe just got roped into gambling. Emotionally vulnerable gamblers tend to have depression and anxiety, but they don't tend to be very impulsive. And then antisocial impulsive gamblers tend to have a lot of psychiatric problems, drug and alcohol problems, legal history, and they also tend to be much more impulsive than these other two groups. So we did a study with 229 participants in a large clinical trial of cognitive behavior therapy, and we were interested to see whether there would be any difference between these three groups in terms of their treatment outcomes. We used a number of questionnaires. We followed them up at the end of treatment and at a follow-up point. And again, we have these three groups: behaviorally conditioned gamblers, emotionally vulnerable gamblers, and antisocial impulsive gamblers. And when we looked at their data just at the end of treatment, we found that among the behaviorally conditioned gamblers, about 40% of them no longer had any gambling disorder symptoms at the end of treatment, compared to about 20% of those, the emotionally vulnerable and antisocial impulsive groups. When we looked at their scores on the South Oaks gambling screen, and we wanted to see what proportion had fewer than 5, which is the cutoff for gambling disorder, we found that about 75% of those in the behaviorally conditioned group no longer met gambling disorder criteria, compared to about 40% in the other two groups, emotionally vulnerable and the antisocial impulsive group. Just looking at this graph would suggest to me, without any other information, that the behaviorally conditioned gamblers who don't have any psychiatric problems, who are not impulsive, do better in treatment. But this graph is a little bit deceiving, and I'm going to show you one more graph that actually shows their change in scores across time. So this graph actually shows their baseline scores on a addiction severity measure, their post-treatment score, and their follow-up score. And what you can see here is there's these three lines: behaviorally conditioned, emotionally vulnerable, and antisocial impulsive gamblers are in different positions. The emotionally vulnerable and antisocial impulsive lines pretty much follow each other along. The behaviorally conditioned gamblers line is much lower on the graph than the other two lines. But one thing you notice about all three lines is they follow the exact same trajectory, which means that all three groups got better at the exact same rate. So the behaviorally conditioned, the less severe gamblers, got better at the exact same rate as the very highly impulsive, antisocial impulsive gamblers. What this to me means is that people with impulsivity problems, executive function problems, there's no reason to be pessimistic about their treatment. What they essentially need is probably longer treatment and sometimes more intensive treatment to get them to their treatment goals. So that's where I'm going to leave us today. And I'm not sure if we have any time for questions, but I'm certainly willing to open it up there, Robbie.
Hey, Dave. Yeah. Hey, great. That was great. And I love how you wrap that up with the pathways and that there's always hope, right? Because not every problem gambler is the same. So that was a great way to wrap that up. And I think that's so, generally speaking, in the behavioral health field, especially with addictions, either if it's a addiction like gambling,
Mm.
or something, like substance use disorder as well. So, but with saying that, and with the questions, we do have a chat question. And if you have any questions, guys, it might be best at this point, because of the number of folks that we have, and because of the system we're working with, it might be best to text. But we do have a question here from one of the participants. I don't have a name, I've got a number, but asking, or it might be a statement here, but let me read it for you, Dave. I wonder if the person is a trauma survivor, if the brain was already hijacked by the unbearable, and impulsivity is a survival strategy to just numb the pain.
Mm-hmm.
And I saw when this came through, I believe this came through on the earlier,
Yeah.
portion, the study right before this last pathways one.
Mm-hmm.
When you were talking about,
So this is
yeah,
related to Dolores, right?
I believe well,
Yeah.
it might be, yeah.
I think absolutely. The question is, yeah, probably so. I mean, if you think about the substance abuse literature, we find there's high impulsivity, but there's also super high rates of trauma. Both sexual abuse and other forms of trauma among people with addictions. And in fact, we did a study we published a few years back where we assessed people who were in gambling disorder treatment about their trauma exposure, and we found, first of all, a third of the people that we actually assessed met at least screening diagnostic criteria for post-traumatic stress disorder.
Mm.
And then among the other 2/3 of the problem gamblers we assessed who did not meet PTSD criteria, 87% of them had experienced a significant lifetime trauma, at least one.
Wow.
That could be related to post-traumatic stress disorder, but they didn't endorse as many symptoms. So I think that trauma is a big part of the hijacking the reward system,
Mm.
and I think people develop addictions as a little bit of a chicken and the egg problem as to what comes first. But I think that the two go hand in hand for sure.
I got you.
Mhm.
Um, yeah, a nice answer. A nice question. Thank you for the question. We have another question. It might be our last here, since we have just a couple of minutes left. And this comes from Mitchell. Is there a way to control executive functioning?
Is there a way to control it, like to get to
Yeah.
improve it? I guess. I mean, I think you can practice for sure. I think to be aware of it will help. Like if you are aware, for example, that you have cognitive flexibility issues, I think that you can compensate in certain ways. I know for me, when I've done work with people who have, say, head injuries or other things where some aspect of their executive function is compromised, that the one thing that does seem to sort of work is to try and find some way to compensate for the problem. So for example, if someone's having deficits with planning, then maybe what they need to do is be more organized and sort of have a way of sort of writing down the things that they need to do, the steps that they need to take. Sometimes you can improve some of that, but for the most part, I think you need to compensate for it.
Yeah. Yeah. Nice. Yeah. Great answer. And thank you, Mitchell, for that question. That's a great question. Yes. And he says very good information. Yeah, I like that, Dave. So in other words, being able to inventory and find out what areas need help is just half the battle, right?
Right.
And yeah, absolutely. And being
Mhm.
able to perhaps maybe come up with ways to work on those areas if there are. But I
Right.
guess I get it. Yeah.
Mhm.
Okay, well, we're right at the hour, guys.
Oh,
And
okay.
Dave, I would like to thank you
Robbie, thank you.
today. Yeah, that
Yeah,
was
it's great.
great. Great information. I always love when you tie in some of the studies on the brain and how
Hmm.
it works and how it's related to, gambling disorder, problem gambling, and even substance use disorders. So,
Absolutely. Hmm.
yeah,
Okay, cool.
very good
Great.
stuff. And
Oh,
by the way, guys, this version will be recorded and will be up, I believe, on the UNC website that I spoke of earlier, the behavioral health springboard. But we will have the recording posted hopefully soon, and we look forward to next week, March 5th, with Dan Trolero, who will be talking on, I believe, sports gambling, and then the following week I will be talking on one-on-one on assessing and screening. So we wish everybody to have a great afternoon, and thanks again, Dave.
All right. Thanks very much, Robbie.
Okay, everybody have a great day. Thank you.
I know.
All right.